Welcome to the Scientific Sense podcast, where we explore emerging ideas from science, policy, economics, and technology. My name is Gill Eapen. We talk with world's leading academics and experts about their recent research or general areas of topical interest. Scientific Sense is an unstructured conversation with no agenda or preparation. We cover a wide variety of domains where new discoveries are made and new technologies are developed on a daily basis. We are most interested in how new ideas affect society and help educate the world how to pursue a rewarding and enjoyable life rooted in science, logic, and information. We seek knowledge without boundaries or constraints and provide unedited content of conversations with researchers and leaders who love what they do. A companion blog to this podcast can be found at scientificsense.com, and this podcast is available on over a dozen platforms and directly at scientificsense.net. If you have suggestions for topics, guests, and other ideas, please send them to info@scientificsense.com, and I can be reached at gill@eapen.info. My guest today is Professor Anish Chagpar, who is a professor in the Department of Surgery at Yale School of Medicine. She is a well-known breast surgical oncologist who participates in investigator-initiated and cooperative group clinical trials, as well as translational and clinical research. The results of one of her recent clinical trials to improve outcomes in breast cancer surgery were published in the New England Journal of Medicine. She teaches an online course on Coursera entitled An Introduction to Breast Cancer and co-hosts a radio show and a podcast called Yale Cancer Answers. Welcome, Anish.
Thank you, Gill. It's so nice to be here.
So I would like to start with your insights, exploring a bit on the causes of cancer. We know there are a variety of causes. It's probably a complex multifactorial problem. But there are things like certain types of virus, perturbation of the microbiota in the gut, perhaps in the breast, in the case of breast cancer, exposure to chemicals, hormone imbalances, genetic abnormalities or mutations, and of course, lifestyle. There may be others. So if you can talk about some of these risk factors, for example, what's our latest thinking on viruses causing cancer?
Yeah, so, as you mentioned, it is a very complicated, multifactorial kind of thing. And it really isn't simple, because if it was simple, we would have figured out the unifactorial cause of cancer and prevented it or cured it by now.
Yeah.
But I think that there are a few things to keep in mind, and I always like to break down these complicated concepts into simple ones.
Mm-hmm.
So the first is that all cancers are different, and they're different not only in terms of the organ system at play. So lung cancer is different from pancreatic cancer, is different from breast cancer.
Yeah.
But they're also different in terms of individual biology, right? So one person's breast cancer is different from another person's breast cancer.
Yeah.
Now, when we think about, so that's one layer of complexity. When we think about the causes of cancer, in the most simplistic model of thinking about it, I like to break it down into two main buckets.
Yeah.
There are the genetic factors and there are the environmental factors.
Mm-hmm.
So when we think about what exactly is cancer, like how does it work? The simplest way to think about cancer is that it is cells that have gone wild.
Right.
So normal cells get mutated such that they lose regulation that normally controls their growth. So a cancer cell essentially is like a cell that has an accelerator pedal but no brake pedal.
Mm-hmm.
Now, all of our cells need regulation. All of our cells grow and differentiate. That's how we, become normal human beings. It's how we evolve over our lifetime, and how our cells regenerate. Those are really important processes, and all of those processes are dictated by our genes.
Yeah.
But part of that is also the regulation of that. So how often our cells grow, develop, die, regrow, etc. And so what happens in cancer, in part, is that there are abnormalities that occur in these genes that essentially put on the accelerator pedal and take away the brake. So remove the regulation.
Yeah.
And so from a genetic standpoint, the simplest way of thinking about it is that there are genes that are called oncogenes, which, when turned on, really spur on a cancer.
Mm-hmm.
And there are genes which are called tumor suppressor genes that, when turned off, lose that regulation. So they essentially make cancer. So if you take away the suppression of a tumor suppressor gene, you essentially turn on a cancer.
Right. So, like you say, you can think about this as the genetic factors as well as environmental factors, but foundationally, mechanistically, two things that happens: oncogenes turn on, or tumor suppressor genes turn off, and that essentially leads to, as you say, sort of a runaway mechanism in the body. But what's our thinking now? I sometimes I haven't read about this a lot lately, but people used to think about this sort of a hit and run mechanism for virus and bacteria and all of that. So what's our thinking now in terms of external organisms causing this issue? Yeah.
So absolutely right. So once we have kind of that framework, right, of how these genetic mutations can actually spur on a cancer, then the next question is, well, how do the oncogenes get turned on, and how do the tumor suppressor genes get turned off?
Right.
What is it that causes that? And this is where we get into all of these other factors.
Yeah.
So when we think about viruses, and there are a number that we could talk about that are viruses that cause cancer. For example, the most common is probably thinking about HPV.
Yeah.
So HPV can go and essentially manipulate the DNA, right? Because how do viruses work? Viruses attack a cell. They then incorporate their DNA into the cell, and they hijack the cell, right?
Mm-hmm.
And so this is how viruses work. And when they hijack the cell, they can then turn on proto-oncogenes, make them into oncogenes, or turn off tumor suppressor genes. And so whether you're thinking about HPV, which is a cause of cervical cancer, anal cancer, head and neck cancer, or whether you're talking about other viruses like hepatitis B, which is a risk factor for liver cancer, this is one mechanism of inducing DNA damage. Now, there are other mechanisms too. So, the other bucket, remember, is environmental causes, right?
Yeah.
So when you think about that, it still boils down to what is happening, what exposure do you get from the environment that ultimately causes your cells to have this runaway mechanism. So think about, it's summertime now. Think about melanoma. How does that occur? Well, UV radiation, UVA and UVB rays that penetrate through the stratosphere actually can penetrate the skin. And when they do that, they can penetrate cells and they can cause DNA damage. That DNA damage then can, again, start this whole cascade of mutations. And so there have been a number of molecular pathways that have been elucidated that help us to understand some of the mechanisms of these of these cancers turning on, whether from genetic causes or environmental causes. And once we realize these mechanisms, a number of things can happen. So first off, when we think about viruses, I think one of the important things is that if we find a virus that is etiologically linked to particular cancers, we're able often to find a vaccine. And so one of the greatest things in cancer prevention that's occurred is the HPV vaccine, which is very, very good in terms of preventing cervical cancer and other kinds of cancer. The other thing is that we can think about prevention. So when we think about the example with UV rays and melanoma, we know that there's a benefit of, the 5 S's, right? Slip, slap, slop, seek, and slide in terms of protecting yourself from the sun, and the benefit of sunscreen. But the other thing that has happened is, as we've started to figure out mechanisms that occur both outside of individual cells and within individual cells, of how these mutations occur, right? Your cell is exposed to an exposure, whether it's a virus or whether it's an environmental toxin or whether it's a hormone, right? So take, for example, estrogen in the case of breast cancer. So breast cancers, about 80% of them have an estrogen receptor. And so when stimulated by estrogen, they actually can proliferate. And similarly, we found with HER2, HER2 is a tyrosine kinase receptor, that in these cells that overexpress HER2, you essentially turn on this mechanism where the cell gets stimulated to reproduce. And so by kind of figuring out what are these various factors that are going on within cells, you can then figure out how to block them, whether with endocrine therapy in the case of estrogen, anti-HER2 therapy in the case of HER2. Similarly, we've looked at, discovered growth factors and growth factor receptors like EGFR, which is epidermal growth factor, which is something that we often see in lung cancer, and now there are drugs targeting that. So there's a number of ways of figuring all of that out. And I think,
Go ahead.
Go ahead. Well, I think that the other thing that is a hot topic right now is this whole concept of, well, okay, once we've figured out all of these kinds of things, this low-hanging fruit, we still find that there are some cancers that, we can't target with our drugs, or that evade the immune system, because ultimately the job of your immune system is to kind of figure out what is foreign, what is abnormal, and clear it, right? But cancer cells are pretty smart in the sense that I think a bit of it boils down to evolution and survival of the fittest. So cancer cells kind of figure out how to survive. And one of the ways to survive is to evade the immune system. And so now this is another very active area of research, which is to try to combat the invisibility cloak that many of these cancer cells put on. So how do we make them appear to the immune system so that the immune system can attack them? So I think, looking at all of these different causes of cancer and how DNA damage occurs and how cancer cells actually turn on, have really led to a variety of therapies and preventative strategies that we use all the time.
And the other side of virus, of course, is bacteria, and more generally the microbiome. And I know that there are a lot of influences of related to obesity, type 2 diabetes, things like that, which are also related to perhaps the dynamic balance of the microbiome. So, what's our current view as to the importance of microbiome as far as cancer causes go?
Yeah, so this is another hot topic of investigation currently. We know that you've got in your gut some good bacteria, and that this is really important for your GI tract's microflora. And, historically, people have thought, well, that's all well and good. That's fine for thinking about maintaining that gut microbiome for colon cancer. And certainly that's an area where there has been some study, particularly, for example, in thinking about dietary interventions like increasing dietary fiber, which helps to maintain your gut's microbiome, and has also been shown to reduce your risk of colon cancer.
Mm.
But now people have started to really look at the gut microbiome and think about this as not simply being a local factor, right? Because your gut microbiome actually may have more systemic effects in terms of inflammation.
Yeah.
And so then you start putting together the cascade of inflammation, infection, and cancer, because your immune system is wrapped into that whole kind of network as well. And so this is an active area of study. So, for example, there is a trial that I'm involved in currently, looking at diet and exercise in cancer survivors, which is a follow-on from the LEAN trial, which also looked at diet and exercise. But this is really one of our endpoints, is to look at the gut microbiome and look at it in terms of inflammation, and how we might be able to figure out the impact of the gut microbiome on cancer.
Yeah, and as far as breast cancer goes, there is also sort of a microbiome environment in the breast as well, I would imagine, right?
Yeah, no, absolutely. So anytime we think about, the microenvironment of cancers, you always need to think about that, right? So, I mean, this goes back historically to people who were talking about concepts like the seed and soil hypothesis, right?
Mm.
So, how can a cancer grow? It needs to be in a particular environment. And so, people have looked at, what are the factors in that environment that help cancers to grow. So when we think about the hallmarks of cancer, and this goes back to studies that were published in the Lancet that I think many listeners may be aware of, thinking about things like angiogenesis and having factors that help cancer cells kind of diapedese into blood vessels and gain access into lymphatics and so on. And so there needs to be a microenvironment
Yeah.
around the cancer that allows it to grow and develop.
Yeah, and thinking about the environmental factors, there are a couple of topical things. Bayer settled a lawsuit about $10 billion for Roundup weed killer
Mm-hmm.
just last week, I think, and Johnson settled around the talcum powder issue. So it seems like the chemicals that you're exposed to, especially again from a breast cancer perspective, gasoline and chemicals formed by combustion always had a negative thing around that, right?
Well, I think we need to be careful because, it's always difficult to kind of separate out association from causation. And there
Yeah.
have been some studies, that really haven't found that all chemicals cause all cancers. So this goes back to what we talked about at the very beginning, which is that all of these different cancers are different. So, for example, we know that certain chemicals will cause bladder cancer, and that's been a well-established link.
Yeah.
We certainly know, I mean, one of the easiest examples is cigarette smoke. Cigarette smoke will certainly cause lung cancer. I mean, that causal link has been well established. However, if we look at cigarette smoke, for example, and breast cancer, that really has not been shown to have a causal link. So when patients come to me and they say, does cigarette smoke cause breast cancer? I begrudgingly have to say, well, no, we don't have data of that causal link, but it will cause heart disease, lung cancer, poor dentition, and a number of other things that will result in your early demise. So please don't smoke, but I can't tell you not to smoke because it causes breast cancer.
Yeah, I mean, the complexity of cancer, as you said before, it's truly a personalized disease, right? Every organ is different, every individual is different. And essentially, cancer is also an evolving mechanism. So when you catch it, it has significant impact on what you see at that point in time as well.
Yeah, undoubtedly. I mean, not only is it evolving over time. So, for example, early detection is really critical, right? You have, a mammogram and you catch a cancer when it is, a few millimeters, your prognosis is much better than if you, catch cancers when they are metastatic or certainly locally advanced or very large. The other thing, however, is that even within an individual patient, cancers can evolve. So when we look at cancers in a primary site, so for example, cancer that is in the breast versus that same cancer that has spread to a distant organ, we may find different biomarkers in different sites because, as I say, cancer is smart, right? It's going to evolve, and as it mutates, right, it will lose some of that normal differentiation. So remember that cancer is essentially normal cells that acquire these mutations that cause them to become abnormal. So when we think about cancer, we talk about grades of cancer. Well, low-grade cancers essentially look as close to normal as you can get while still being a cancer. But, cancers can become higher grade. They can lose some of that differentiation that makes them look like normal cells to look really abnormal. And so even in an individual, as that cancer kind of spreads and evolves, it can change.
Yeah, yeah. And from a diagnostic perspective, I saw a study that said something like 3D mammograms outperform traditional 2D mammograms. What exactly is a 3D mammogram?
Yeah. So, when we think back to mammography, the simplest way of thinking about it, and any woman who has had a mammogram who's listening to this podcast knows what it's like, right? You go, your breast is squished between two plates, and orthogonal images are taken. And historically, what that did is it gave us 2D images of a 3D structure, right? So you take one picture up and down, you take one picture side to side. Essentially, you get two-dimensional pictures, and you put together in your mind a picture of three-dimensional space.
Yeah.
So one of the issues with that is that you can imagine that if you have dense breast tissue, and this is another concept that people may have heard about.
Yeah.
So when we think about the breast, right, the breast is made up of fatty tissue and fibrous tissue. Now, on a mammogram, fatty tissue looks black, fibrous tissue looks white. The younger you are and the denser your breast tissue is, the more fibrous tissue you have.
Yeah.
So the mammogram is more likely to look white. Now, here's the problem. Cancer also looks white. So it's harder to see white on white, right?
Right.
And you can imagine that if you now take a dense structure, right, that's got mostly fibrous tissue in it, and you squish it, right?
Mm-hmm.
So essentially, you've made this even look more dense when you get these two-dimensional pictures.
Yeah.
And so then the question was, well, how can we do this better? And so what tomosynthesis is it is a technique where the machine will take fine slices
Mm-hmm.
through the breast.
Yeah.
You can think of it kind of like a CAT scan of the breast,
Right.
except it's taking these thin slices in each of these two-dimensional planes. So you can now page through that dense organ and look from left to right, for example, or from top to bottom through what would normally be one two-dimensional picture.
Yeah.
And so what happens is you find that you are better able to find cancers, especially in dense breast tissue, because each of these slices, very much like looking at layers of onion skin, instead of looking through the entire onion, you're now looking through an individual onion skin,
Right.
multiple onion skins. So it's easier to see things. And so this technique is what they call 3D mammography. It's
Yeah.
also called tomosynthesis. And by and large, it really has become far more commonplace. And so most places these days will automatically do a 3D mammography or tomosynthesis, at least in, Canada, the United States, in the Western world. Now, the situation in developing countries is another issue altogether.
Right. Is MRI a better modality in such a situation when you have dense breast?
Um, Not exactly.
Okay.
So here's the deal with MRI.
Yeah.
MRI is incredibly sensitive, but it has a number of disadvantages.
Mm.
So number one is you need to be injected with a contrast material called gadolinium in order for us to see the wash in and wash out kinetics, which helps us to interpret the MRI. Now, the problem with that is, just like you were saying about chemicals, what we know about this gadolinium is that it is deposited in your brain.
Right.
And we know that if we go back and we look at people who have had MRIs, we find these gadolinium deposits. We have no idea what it means. And so that's the first issue, is that people might not want to get gadolinium in their brain.
Mm.
The second issue is that this is very claustrophobic. Anybody who's had a breast MRI, you're in a very tiny hole, which is really uncomfortable for a lot of women.
Yeah.
The third issue is the cost. MRI is insanely expensive, particularly when compared to mammogram. And so as a screening test, it doesn't seem to be ideal. The fourth issue is it's very difficult to do an MRI guided biopsy. Whereas with mammogram, it's very easy to do a biopsy if you find something. So anybody who has had an MRI that has found an abnormality, what you find often is the radiologist will do an ultrasound. And people come to me and they say, why are they doing an ultrasound and trying to do the biopsy under ultrasound? And that's because it's difficult to do the biopsy under MRI. And so putting all of that together, oh, and one more thing.
Yeah.
If you look at the randomized control trial data, there have been over 8 randomized control trials demonstrating a survival benefit for mammography. We don't have that evidence for MRI, simply because it's not a good screening test for all of the other reasons mentioned.
Right.
And so MRI is really reserved for people who have a genetic mutation, a BRCA1 or 2 gene mutation, or they have a family history such that if you put them into a model like BRCA Pro, they would have a greater than 20 to 25% lifetime risk. But outside of that, most clinical practice guidelines put out by professional societies have recommended against doing screening mammography for the general population.
Right. Yeah. So, I want to also get your perspective on, from a policy perspective. I saw a few studies, and one of them says expanding Medicaid linked to fewer women diagnosed with later stage breast cancer seems very intuitive. what is your perspective on, clearly catching it early, making preventative, diagnostics as well as treatment has a significant impact on outcomes. Do you think our healthcare is really set up to do that effectively, or what's your perspective?
Yeah, so we've done a number of studies looking at this, and if you look at screening mammography, which we've already established, right, saves lives. We've got over 8 randomized controlled trials that have demonstrated this. I think this is well known. Um, we find that one of the key factors, more than anything else, is your insurance status,
Yeah.
and whether you have access to, a family physician who can refer you for a mammogram. And so this is really a problem when you live in a country where so many people don't have health insurance.
Right.
I mean, even without that, there are other excuses that women have for not getting their mammogram, right? I was too busy. I didn't think about it. Whatever. I didn't want to go through the pain. I found it uncomfortable. I didn't know that I was supposed to get a mammogram. There was a distance to the hospital. I couldn't go, whatever.
Yeah.
But, when we think about what is actually going to change health outcomes, whether in screening or anything else for that matter, right?
Mm-hmm.
It really is access to care. And when you think about, the leading cause of bankruptcy in this country is healthcare costs,
Yeah.
which, by the way, are rising exponentially.
Yeah.
And so we're one of the very few countries in the world who don't offer universal health care to our populations.
Right.
And I think that is to our demise. We have the highest rate of healthcare spending, but we don't have the outcomes that correspond with that. And, you have to start thinking about, well, why is that? And I think one of the issues is that we have a big chunk of our population who don't have access to care because they don't have insurance.
Yeah, I mean, access to care, and if you look at total cost of care, right, and this is what we often miss, both from a policy perspective as well as from a general economic perspective. Early diagnosis, prevention, all of those have significant value to society if you
Yeah.
implement it, across the board. There was a study that suggested that insulin resistance is one of the major reasons why Black women have worse breast cancer outcomes compared to white women. And so insulin resistance, type 2 diabetes seem to have, a huge impact, right, on all sorts of diseases. Maybe hypertension, type 2 diabetes, and few others might be responsible for perhaps half our healthcare costs.
Mm-hmm.
And if we catch it and maintain it preventatively right from the beginning, it could substantially reduce total cost of care, but it does require sort of a systematic change how healthcare is delivered, I would imagine.
Well, not only that,
Yeah.
Gill, but I also have a YouTube channel called Chagpar MD, and I recently interviewed Rachel Perry, who is a scientist here at Yale, who does a lot of work at the intersection of insulin resistance, obesity, and cancer.
Yeah.
And one of the things that she'll tell you is that with the rate of obesity increasing as it is currently, the expectation is that within the next decade, everyone will have type 2 diabetes. And part of the issue is that we have this obesity epidemic in our country. And I think part of that, when you think about prevention, right?
Yeah.
Think about our lack of physical activity. So sitting is the new smoking. and the fact that there are systemic issues in terms of our nutrition, right? Not only from a awareness standpoint, but there are large sections of the country where there are food deserts, right? Where people, particularly people who are of minorities or of poor socioeconomic status, simply do not have access to healthy nutrition. You know, we've seen that even during this COVID pandemic, where one of the big issues was if kids aren't going to school, where are they going to get healthy nutrition?
Yeah.
So, you know, I think that when we think about, well, what is the solution to so many of our healthcare woes? You know, I agree with you. I think that it is broad spectrum kind of thought as to how can we prevent disease by increasing physical activity, improving nutrition, improving preventative health care, access to care, screening tests for cancer, basic things that can help us. And I think that that really boils down to how can you really build in an infrastructure in your healthcare system that provides that equally to everybody.
Right, right. Yeah, it's almost like sort of a binary design in the sense that unless you look at all the aspects that you mentioned, you're going to get suboptimal outcome, right? So if I put band-aids here and there,
Mm-hmm.
it's going to be ultimately more costly and with suboptimal outcomes. So it seems to me that to really really make an impact, you have to design it from bottoms up, and you have to touch on all aspects of that, all the things that you said, in terms of diagnostic, preventative care, access to care, and really continuous care. Medication compliance is often an issue. So we could potentially use technology in some of those areas to make that better. I want to jump into one of this. You did a fascinating clinical trial, and had a paper in the New England Journal of Medicine. It's entitled "A Randomized Controlled Trial of Cavity Shave Margins in Breast Cancer." And I think there were two such studies, right? The shave study as well as the shave 2 study. Could you talk a little bit about that?
Yeah, so this was again a intervention really designed to improve the quality of care of patients undergoing breast cancer surgery, and to do it in a cost-effective way.
Yeah.
So we know that, you know, every year in the United States, about 300,000 women are diagnosed with breast cancer. And the vast majority of them are diagnosed early, thankfully, right? Because we do actually have screening mammography, and about, 75% of eligible women will avail themselves of that. So we tend to pick cancers up early.
Yeah.
The nice thing about that is that then patients can have what we call a lumpectomy or a partial mastectomy to remove that cancer, rather than losing the whole breast. But what's important is that when we take out that cancer, because remember, we can't see this or feel this, it's just these microscopic cells.
Yeah.
We rely on the radiologist kind of pinpointing for us where the biopsy was done. So this is why they'll often put in a little marker at the time of the biopsy to show us where this is. And then when we take it out, we x-ray it in the operating room. So we can look at, where is that little clip? Is it close to an edge, or does it look like it's right smack dab in the middle?
Yeah.
And the idea is that you want to take normal tissue all the way around. Well, you can't see cancer cells, but you can look at the image and you can kind of say, I think that the clip is a little bit close to one edge. I'll take a little bit more on that side. But what we found, and what has historically been the case, is that 20 to 40% of patients, when you do this operation, and then you give the specimen to the pathologist takes about a week or so to look at the whole specimen. And 20 to 40% of the time, they're going to tell you that you're close to an edge that you didn't take out enough of,
Right.
that you need to go back.
Yeah.
And so you can imagine what that's like for patients, for physicians, for the healthcare system. Nobody really likes that.
Right.
So one idea was, well, maybe we should just take out more tissue all the way around. And certainly some surgeons were already doing that. Other surgeons like me, however, said, I don't really understand how it can make much sense to take out more tissue all the way around when you can look at the specimen radiograph, you can see where you're close. Why not just take more on that particular side? Because you're taking more tissue. What could be the downside of doing that?
Yeah.
And so some surgeons said, well, when we compared surgeons who took out a little bit more to surgeons who didn't, they actually weren't taking out more tissue. And I said, well, that doesn't make any sense. That's a retrospective bias where, you're comparing surgeons who know that they're going to take out more. So they hug the cancer and then they take out more, versus surgeons who take out more to begin with. And because they know that they're not going to take out more, they take out a bigger specimen. So the two end up being equal. So what I said was, in order to really test this, let's surgeons who selectively shave, so take out a little bit where you think you're close, and tell them at the time that you have done your best operation and you're ready to close, then we will open an envelope in the operating room, so you'll be blinded up until this point, and we will tell you either no shave because you were going to close, so close, that's what you would normally do,
right,
or just take out more all the way around, shave.
Right.
And so in doing this trial, this was therefore very objective, right? We knew that if the surgeons were going to take out more, there would be more tissue taken out, and there was.
Right.
But then we also looked at the positive margin rate, the chances of having cancer at the edge. And what we found was that by taking out more tissue all the way around at the time of the first operation, you cut the positive margin rate in half, you cut the reoperation rate in half. It did add about 10 minutes to the operative procedure, and it did add to the pathology costs, right? Because you were generating more specimens for the pathologist to look at. But that cost was offset by the reduction in reoperations.
Yeah,
so
50% reduction is a big deal, right?
That's a big deal.
Yeah.
And that's why it ended up on the front page of the New England Journal with a wonderful editorial complimenting us on doing this trial. But one of the questions that then arose was, okay, that works at Yale. Does it work anywhere else in the world?
Right.
And so we got together 9 other centers from around the country that varied, right? They varied in terms of geography. They varied in terms of patient population. They varied in terms of, were these general surgeons or breast surgeons? Were they community practices? Were they large academic practices? And we had them do the same trial.
Yeah.
And that was the SHAVE 2 trial, which was published a couple of years ago, which found the same thing. In fact, it found that the reduction in positive margins and re-excision was actually closer to 70%. And so this was really a big deal, and I think has become practice changing because it's a simple technique. It doesn't require any fancy technology or anything to do, and can make a real difference for patients. But now the question is, how can we do even better? And so that's the next task.
Yeah. So this is now becoming sort of the standard of care.
I think so.
Yeah.
I think the vast majority of surgeons around the country and around the world have really adopted this, because now you have level 1 evidence, not only from the SHAVE trial and the SHAVE 2 trial, but it's also been replicated by another smaller trial that was done in African American patients. So many people have adopted this as standard of care. Now, there are still some surgeons who are a little bit reluctant because they say, we are taking out more tissue, and what will that do to the cosmetic result? We're looking at that in terms of our data, and trying to figure out how we can improve the technique such that we can still keep the benefit of reducing the recurrence rate and the re-excision rate, while taking out less tissue. And the next thing that's going to happen as we look at our 5-year data, which we'll be getting this year, is to look at the recurrence rate.
Yeah.
Because some will argue that these days we have really good radiation therapy, we have really good systemic therapy. Will it make a difference in terms of recurrence? We're not sure, but you would surmise that it would, because we know that positive margins are associated with a 2-fold increase in local regional recurrence, and nobody wants a recurrence.
Right. Yeah. So to conclude on this, Anis, if you look forward, say 5 years on this particular topic, in my sort of simplistic view, this sounds like an optimization problem, right? Precisely how much to take out in the first attempt, so that the probability of requiring more is substantially reduced. Do you see how do you see the kind of technology developments in the next 4 or 5 years affecting that? Perhaps robotics, perhaps some aspects of artificial intelligence. If we can have a better view as to how to optimize that in the first instance, do you think we'll get better and better?
Yeah, exactly. And in fact, that's what we're working on at the moment. And there are a number of people who are active in this space, whether using optical agents to try and see if they can kind of help us to see cancer cells at the edge, thinking about artificial intelligence, thinking about other imaging techniques. So all of this is an area of a lot of investigation, and something that I'm actually working on as we speak. So hopefully there will be a lot more interesting developments to come in the years ahead.
Yeah, that's great to know. This has been great, Anis, and thanks so much for spending the time with me. And good luck with your research at Yale.
Thank you so much. It's been a pleasure.
Thank you. Bye.